Hello everyone, my name is Dr. Michael Albright and today I'm going to be talking to you about osteoporosis. This presentation is for the general public for informational purposes only, and it's not intended to diagnose or treat a disease. You should talk to your qualified personal health care provider for medical advice. What is osteoporosis? Osteoporosis is essentially thinning of the bone. The bones are less dense and more easily fractured, especially if a patient falls. The bones are weaker in this condition. As you can see in the picture on the left, the healthy bone looks stronger than the osteoporosis bone on the right. And what's depicted is the hip bone, the femur. I sometimes get patients coming to me saying that they have hip pain and they're worried about osteoporosis, but actually osteoporosis causes no symptoms. Over time, it can result in loss of height of an individual if there are what are called vertebral compression fractures in the spine. That's where the vertebrae in the spine become compressed due to a fracture. It can also cause a hunched back if advanced. The medical term for this is kyphosis. But other than that, you can't really feel osteoporosis until a fracture develops. There are certain things that increase the risk of osteoporosis. There are things that you can't change, such as increasing age. Women, it's 3 times greater in women than men. Race, white is more than black. And the family history of osteoporosis. These all increase the risk of osteoporosis. Things that you might have some control over. So low body weight is actually a risk factor for osteoporosis. So if you are too thin, you might need to get your body weight up into a normal range. Cigarette smoking and heavy alcohol use are also linked to osteoporosis. There are certain medical conditions that increase the risk of osteoporosis, such as COPD or emphysema, conditions where corticosteroids are taken long-term, like rheumatoid arthritis, lupus, and Crohn's disease, hyperthyroidism, where there's too much thyroid hormone circulating in the bloodstream, malabsorption syndromes like celiac disease or gastric bypass surgery, anorexia, type 1 diabetes, and then some conditions that cause low estrogen in women or low testosterone in men. Medications that cause or worsen the risk of osteoporosis are steroids, such as prednisone or methylprednisolone or dexamethasone, too much levothyroxine, which is a thyroid hormone replacement medication, prostate cancer medication, seizure medications, medications used to treat breast cancer from coming back, chemotherapy, methotrexate, and tacrolimus. Who should be screened for osteoporosis? It primarily should be women aged 65 or older, as almost 1/3 of this population has underlying osteoporosis. However, in contrast, only 1 in 20 men at this age have osteoporosis. We may also consider screening younger women with many risk factors for osteoporosis or for patients who take corticosteroid medication long term. We screen for osteoporosis using a DEXA scan. DEXA stands for Dual Energy X-ray Absorptiometry. What it does is measure bone mineral density, or BMD, at the hip and lower or lumbar spine. There are 2 possible ways by which osteoporosis can be diagnosed. The first way is a fracture of the hip or one or more vertebrae bones in the spine, regardless of bone mineral density and not due to excessive trauma. And the other way to diagnose osteoporosis is through a DEXA scan, a bone mineral density T-score of -2.5 or less. So what a T-score is actually a statistical measure known as the standard deviation. It compares your bone mineral density compared to a young, healthy 20-something-year-old female patient. You may have also heard the term osteopenia. What is that? Osteopenia is bone thinning that is not severe enough to be classified as osteoporosis. Doctors define this as a bone mineral density T-score of -1 to -2.5. And remember, osteoporosis is a score less than -2.5. A T-score of greater than -1 is considered a normal bone mineral density. Some doctors may treat you with medication for osteoporosis, even if you do only have osteopenia, if your risk for fracture is high enough. So if the doctor does a FRAX score measurement, they may see that your 10-year risk of hip fracture is greater than 3%, or your 10-year risk of any fracture is over 20%, and may consider prescribing medication if that is the case. As I said, this risk is calculated by using the FRAX scoring system. That is sometimes reported on a DEXA scan report, but it can also be calculated through an online calculator. This strategy for reducing fractures in patients with osteopenia has not been proven in clinical trials, so some doctors may only treat you with osteoporosis medication if you do indeed have a diagnosis of osteoporosis and not osteopenia. One of the most common questions I get in clinic are, do calcium and vitamin D help, and how much should I take? Well, unfortunately, numerous clinical trials have not shown that these supplements reduce fracture risk. They may improve bone mineral density. The recommended dietary allowance for calcium is 1,200 milligrams a day for women over the age of 50 and 1,000 milligrams per day for women younger than age 50. The RDA for vitamin D is 800 international units per day for women over age 70 and 600 international units per day if younger than that. If you can get these RDA amounts for calcium and vitamin D through food and drink, that is great. If not, you can use a supplement. Be aware that taking too much calcium and vitamin D could cause kidney stones and potentially other issues, so do not take too much. There are some things that you can do on your own that might help prevent osteoporosis. Increasing your weight if you're underweight, eating plenty of protein in your diet, 0.8 grams per kilogram of body weight are recommended. Avoid smoking cigarettes. Avoid excessive alcohol. Remember, 1 alcoholic beverage or less for women is recommended, 2 for men. Aerobic exercise and strength and resistance training are important. We always say that weight-bearing exercise helps prevent osteoporosis because when you bear weight on your bones, it makes them stronger over time. What about falls? Do they increase the risk for fracture? Yes, of course they do. Falling in older adults is the #1 reason that patients develop an osteoporosis-related fracture. 10 to 15% of falls in older adults result in a fracture. And so to reduce your fall risk, you need to do several things. You need to make sure your vision is optimized, and you need to see your eye doctor for this. You need to minimize medications that cause falls, and your primary care doctor and other doctors could help you with this. You need to engage in long-term exercise training, and sometimes this involves getting physical therapy involved to address any gait or balance issues that you may have. The 2 most common types of fractures that occur as a result of osteoporosis are vertebral compression fractures and hip fractures. Vertebral compression fractures are fractures that occur in the vertebrae bones in the back. Severe pain usually results from these fractures, and the fractures and the pain associated with them occur suddenly. This type of fracture is either treated with pain medication alone and time in order for the pain to improve, but also another procedure that can be done is known as a kyphoplasty, and this is where the fractured vertebrae is filled with bone cement to make it more stable, and this can reduce the pain. Some people develop multiple vertebral compression fractures in their lifetime. Hip fractures are the other type of fracture we worry about with osteoporosis. When these occur, usually it's from a fall. Patients cannot walk when this occurs, and they may have severe hip pain, especially when they move the hip. This type of fracture unfortunately requires surgery to fix, and it often requires several weeks of rehabilitation in order to improve strength after such a fracture. Hip fractures decrease life expectancy and quality of life, and so we should really focus on preventing them. I wanted to show a couple of images that demonstrate what we talked about on the previous slide. The picture on the left shows a vertebral compression fracture. As you can see, in this type of fracture, the vertebrae bone sort of collapses on itself like an old building that's collapsing. And on the right, you can see a kyphoplasty procedure being depicted. So an orthopedic surgeon generally is involved with this type of procedure, and it's done under X-ray guidance. A balloon is inflated in the fractured vertebrae bone, and then this creates a space in which cement or bone cement is injected, and this bone cement can reduce pain and improve the stability of that bone. Now we're going to get into the types of medications that can be used to treat osteoporosis, and the goal of treatment really is to prevent fractures. There are medications that prevent bone breakdown. These are known as anti-resorptive agents. There are also medications that build bone up, also known as anabolic agents. And then there are medications that do both. The first type of medication I'm going to talk about are the bisphosphonates. And I'm going to talk about these medications a lot because these are the primary means of treatment for osteoporosis for most patients. As I said, they're the most commonly used first-line group of medications used to treat osteoporosis. They are anti-resorptive agents, meaning they prevent bone breakdown, but they don't build bone up. The generic drug names for bisphosphonates end in dronate. This slide shows a table of 4 different bisphosphonate medications. You can see in the left-hand side of the table, the names of the medications all end in dronate. Alendronate is Fosamax, Ibandronate is Boniva, Risedronate is Actonel, and Zoledronate is Reclast. Alendronate is probably the most commonly given medication, usually by mouth once a week. This medication reduces the risk for both vertebral and hip fractures. Boniva is a pill given once a month, or it can be given via intravenous infusion every 3 months. Unfortunately, it hasn't been shown to reduce the risk of hip fracture, and so we don't use it as commonly as the other bisphosphonate medications. Risedronate or Actonel is a pill given daily, weekly, or monthly, and Zoledronate is an intravenous infusion given once yearly. All medications have the potential to have side effects, and bisphosphonates are no different. Acid reflux is the most common for the oral bisphosphonates, and so we should avoid in patients who already have severe acid reflux that's not controlled with medication, and for other conditions that worsen the risk for problems with the esophagus, such as esophagus motility disorders, Barrett esophagus, esophageal strictures, etc. Some patients get other GI side effects, abdominal pain, diarrhea, or constipation. This is uncommon. Less than 5% of patients will get one of these. With Reclast or Zoledronate, an infusion reaction is possible, and this could present with flu-like symptoms. It's usually right after the medication is infused that patients get this, and acetaminophen or Tylenol may help with this, or NSAID medications like Aleve or ibuprofen may help. Mild bone, joint, or muscle pain is also uncommon, occurs in less than 5% of patients. Low calcium levels in the blood, known as hypocalcemia, can occur. This is rarely severe. Inflammation of the eyes, I have never seen personally in a patient, occurs less than 1% of patients. The two side effects that people worry about the most, and they read about these online, are also the rarest of all the side effects of the bisphosphonates, and these are osteonecrosis of the jaw and atypical femur fractures. These occur in less than 1 in 10,000 patients. The risk generally increases the longer you're taking the drug. They are, especially osteonecrosis of the jaw, is more common in cancer patients who are getting the intravenous formulation reclassed of the bisphosphonate. And what osteonecrosis of the jaw is exposed bone in the facial region that does not heal within 8 weeks after identifying the problem. A systematic review found that 94% of these cases occur in cancer patients taking intravenous bisphosphonate therapy. So it's not even osteoporosis patients primarily that get this problem, but it can occur, and so we do think about it, even though it's extremely uncommon. Risk factors for the condition include corticosteroid use such as prednisone, poor oral hygiene, chemotherapy, smoking, diabetes, and a recent dental invasive procedure. Your dentist may want you to stop the bisphosphonate before and after a dental procedure to allow for healing to reduce the risk of this rare condition. Atypical femur fractures are also uncommon. These are fractures in the middle of the femur, which is the long bone in your thigh. It's estimated that bisphosphonates actually prevent 130 osteoporosis-related hip fractures for every one atypical femur fracture they cause. Your doctor may consider a drug holiday from the bisphosphonates. A drug holiday is a break from taking the medication for a while in order to prevent the side effects. For oral bisphosphonates, it's recommended 5 to 10 years after starting an oral formulation to do a drug holiday to reduce the risk of these very rare side effects, such as atypical femur fractures and osteonecrosis of the jaw. For the IV formulation, 3 to 5 years is recommended before doing a drug holiday. Notably, bisphosphonates are still effective at preventing fractures after they are stopped because they incorporate into your bone and strengthen them over time, even years after stopping them. Some physicians may restart bisphosphonates a couple of years after a drug holiday, whereas other doctors may decide to keep you off of the drug long term. Who should avoid bisphosphonates in the first place? Those with low blood calcium levels or hypocalcemia, those with severe chronic kidney disease or an estimated GFR less than 30, those with acid reflux or problems with the esophagus, those with the inability to be upright for 30 minutes after taking the oral formulation. Remember, with the oral formulation of bisphosphonates, such as alendronate, you want to drink a full 8-ounce glass of water and then remain up in an upright position for 30 minutes after taking it. Those with a history of allergy or severe reaction to a bisphosphonate in the past, of course, should not take it in the future. Another commonly used medication to treat osteoporosis is denosumab, or Prolia. Prolia is a rank ligand inhibitor. This is something you'd learn about if you went to medical school, but you don't really need to worry about it otherwise. All you need to understand is that it works differently than bisphosphonates, and it works also by preventing bone breakdown, just like bisphosphonates do. Prolia is a subcutaneous injection every 6 months, continued indefinitely. It helps prevent both vertebral and femur fractures. Unfortunately, if you stop this medication, the effects wear off. So bisphosphonates work for years even after stopping them, but Prolia does not. And so if you can take a bisphosphonate after stopping Prolia, you should. Possible side effects of Prolia are eczema, which is a skin reaction, nausea, injection site reaction, and then very rarely low blood calcium or hypocalcemia, osteonecrosis of the jaw, and atypical femur fracture. Raloxifene or Evista is an uncommonly used medication used to treat osteoporosis. It also prevents bone breakdown. It sort of mimics estrogen. It's a selective estrogen receptor modulator. It can help some in preventing breast cancer. Unfortunately, it does not prevent hip fractures. It has only been shown to prevent vertebra fractures. It's a pill taken by mouth once a day. Side effects can include leg cramps and hot flashes. It can rarely cause uterine polyps or blood clots in the veins of the legs, known as deep vein thrombosis. It must be avoided in patients with a history of venous blood clots. It's not typically used because of the relative lack of effectiveness, especially for hip fractures, and the risk of side effects. There are also parathyroid hormone mimicking drugs. There are two on the market, teriparatide or Forteo, and abaloparatide or Tymlos. These are subcutaneous injections administered once a day for 1 to 2 years. Unlike the bisphosphonates and Prolia, they encourage rebuilding of lost bone. Side effects can include nausea, dizziness, headache, and joint pain. Abaloparatide or Tymlos can cause a fluttering heartbeat sensation in the chest, known as palpitations. And these medications can rarely cause low blood pressure with the first few doses and high blood calcium levels, known as hypercalcemia. These medications should be avoided if patients have hyperparathyroidism, high calcium levels in the blood, kidney or urinary tract stones, and also be cautious if patients have a history of gout. Blood calcium, albumin, vitamin D, phosphorus, kidney function, alkaline phosphatase, and urine calcium and creatinine should be checked prior to starting these types of medications. Romosozumab, or Evenity, is a sclerostin inhibitor that also helps prevent bone breakdown and builds up bone. So it's the one medication on the market that both prevents bone breakdown and builds up bone. It's a subcutaneous injection once a month for 1 year. After it is stopped, a bisphosphonate or Prolia must be started. Side effects include joint pain and headaches. Rarely it can cause allergic reactions, osteonecrosis of the jaw, atypical femur fracture, and low blood calcium levels. It also should be avoided in patients at high risk for heart attack or stroke, or with patients with history of either of these, as in clinical trials, it did slightly increase the risk for these conditions. If you were to be treated for osteoporosis to prevent a fracture, which drug should you pick? Usually you'll want to go with bisphosphonates unless there is a reason that you should not take them. Bisphosphonates are the cheapest and work well for both vertebral hip and other non-vertebral fractures. Prevention. They reduce overall fracture risk by 21%. They are the first-line agents for osteoporosis, except for Boniva, which only reduces vertebral fracture and not hip fracture risk. If one can't take bisphosphonates, Prolia is usually considered as the second option, as it works well and is the second cheapest option. The other medications I mentioned that build backbone work, but they are very expensive. They're typically used in patients who've had fractures on the less expensive medications. or if patients have a very low bone density, such as a T-score less than -3.5. Calcium, vitamin D, and kidney function should usually be checked before initiating all of these medications. How often should bone mineral density be checked? Women with normal bone mineral density could have a DEXA checked in 5 to 10 years after a normal reading. Women with osteopenia, which is mildly thin bones, could wait 3 to 5 years before checking a DEXA again. And those on treatment for osteoporosis may repeat a DEXA every 1 to 2 years. Those who suddenly have to take prolonged steroids may need to repeat the DEXA sooner than the numbers described above. These estimates, though, are not based on clinical trials, but expert opinion and also on the experience and clinical judgment of your physician. So you should ask your personal physician when your DEXA should be repeated. Let's go over the key points of this talk. Osteoporosis is a disease where the bones are less dense and are therefore weaker than normal bone. This increases the risk of fractures, especially as the result of falls. Osteoporosis causes no symptoms. It is a silent disease until a fracture occurs. It is the most common in post-menopausal women. Women over age 65 and younger women with strong risk factors, such as prolonged corticosteroid use, should be screened for osteoporosis with a DEXA scan. DEXA scans measure bone mineral density. Osteoporosis is diagnosed either by seeing a T-score of less than -2.5 on the DEXA scan report, or if a person has a history of fracture, regardless of the bone mineral density measurement, and it should be an osteoporosis type of fracture. Other key points: people at risk for osteoporosis can lower their risk by reducing or quitting smoking, limiting alcohol use, exercising regularly, and doing things to reduce fall risk, such as physical therapy if needed, using a cane or walker if needed, getting their vision checked, and reducing medications that could contribute to fall risks, such as those that cause dizziness. Calcium and vitamin D supplementation are not always needed unless a patient is deficient in these on laboratory testing and/or they are not able to meet the recommended daily allowance in food or drink alone. Calcium and vitamin D do not prevent fractures, although they can improve bone mineral density. Bisphosphonates are the first-line medication used to treat patients with osteoporosis. Denosumab or Prolia is considered the second-line medication. Teriparatide, abaloparatide, and romosozumab build back bone but are expensive and are only used temporarily for those at extremely high risk for fracture. It should be noted that all medications have the potential for side effects, whether used for osteoporosis or not. However, these medications' benefits outweigh their potential risks.